useful for eyelashes, but we do need more data. Many patients, if they are having brow hair loss, who really want to be doing something and do not want to be doing intralesional steroids, may use this approach or topical Rogaine. At the end of the day, one has to look at the holistic management of pediatric alopecia areata patients. It's crucial to assess the child's psychological well-being, issues like self-confidence, self-image, and acceptance by peers. Some of this was referred to also in the lecture on vitiligo. There is also the issue of her parents being very anxious, frustrated, guilt, and that needs to be managed as well. No treatment may be an option, and for those patients who want to pursue aromatherapy, there is a double-blind placebo-controlled study in the old archives of dermatology that shows in about 30% of patients that can work. So if they're interested in pursuing that, it's okay, it may work. Again, the emerging directions are the JAK inhibitors. We still have a long ways to go, but there seems to be a light at the end of the tunnel to be able to start to work with medications that will be more targeted and will be able to be used perhaps long-term, maybe not every day, to maintain the disease under control. So what I thought, since this is near the end of the session, that I would share with you how I treat alopecia areata for the fun of it. And it'd be interesting for me to hear just how different this is or similar to what you do. So when the patient comes to clinic, of course the age, the race, the sex of the patient is obtained. The date of the current episode is obtained because the literature says if you have the disease for 2 years or more, the prognosis is not so good, particularly if it's extensive. Then we take a look at start and stop dates of treatments, including current treatments. Maybe people tried something, they didn't use it long enough, or they didn't use a high concentration, and supplement use. Many patients in the United States take many supplements, and many of them are written in a Chinese language which neither the patient nor the physician most of the time understands what they're taking. So we look at, and then we think about this disease duration, we look at the type of alopecia areata. Is it totalis, universalis, is it a psoriasis pattern, is it a child, is it an adult, a teenager? And then we want to know a little bit about their atopy history. Do they have asthma, hay fever? Does it flare? When does it flare? How does that relate to the hair loss? Is there nail involvement? If nails are severely affected, the literature says those patients should have or could have a poor prognosis. And we want to know if there's anything else that we need to be aware of medically speaking. There's alopecia areata, but you want to rule out thyroid disease, iron deficiency, and other autoimmune diseases. And what about that family history? Is there a strong history of autoimmunity? Do these patients have to be followed more closely? We use the severity of alopecia tool or SALT score to document the extent of terminal hair loss. So we divide the scalp into the regions I'll show you on the next slide and document the percent loss in each of these regions and total that. That gives us something to put in the chart to show efficacy at 3 months, 6 months, or during our treatment phase. We also document the extent of body hair loss and where it is at. Is it eyebrows, eyelashes, is it some, is it none? And we look at the nails. Are the fingernails involved, the toenails? Is there some? Is there 20-nail dystrophy? We get a snapshot of the patient. We categorize the patients clinically, as we do in the registry I spoke about earlier today, as patchy. And there are those patients who have persistent patchy disease. They have patches that come and go, and they're never well, but they're always having disease activity. There are patients who have diffuse alopecia areata, where we tell them, in your disease, if you look at a section under the microscope, if there are 100 hair follicles, 5 of them are affected. And therefore you see this thinning, but it's alopecia areata, it's a different variant. And of course, ophiasis and totalis universalis. The laboratory studies that we obtain, I mentioned earlier, thyroid, heme, iron profiles, and if indicated, depends on the patient's history, hormones, autoantibodies. In evolution will be those nutrition labs, including vitamin D, thiamine, zinc, total protein, and again, a history of the supplements helps guide us. Documentation of the disease extent with photographs is very important. People forget where these patches are. We forget where the patches are. We usually take 4 views, and some will advise that photographs should be taken with the patient's cell phone so that they have a record of their own extent of hair loss, because therapy can be slow and it can be very frustrating. So it's good if they can see how well or poorly they're doing. All right, treatment. In our clinics, we tell patients there's no approved drug available to treat alopecia areata, so our approach is based on activity. Our hair pulls test positive. Are they positive all over the head? Are we supposed to sit down and tell the patient they'll be bald in the next couple of days? Or is the hair pull test positive only in certain areas? And should we just target those? We look at the location in our tools, eyebrows, eyelashes, body hair, underarm hair. Does the patient really care? The age of the patient. I mentioned earlier today, I have a patient in her 90s who really, really wants her alopecia areata treated. How extensive is it? The extent doesn't bother us. We go after it, whether it's patchy or extensive. And if we need, we do a biopsy to assess inflammation, the hair cycle, and how the follicles are differentiated. And we always look for associated, untreated medical problems. So let's say these 2 patients come to clinic. Our first choices would be topical or intralesional steroids. Perhaps topical minoxidil if there's some vellus hair that's just being pokey. We combine treatments. If we have a patient with patchy persistent alopecia areata, we treat the whole scalp with shampoo formulations like Clovex or clobetasol in shampoo formulation. It's a wonderful product. There are no studies, but it's a hypothesis and it's worked well for us. Intralesional Kenalog is a very common tool in the practice. This technique has been around since the late 50s. The side effects tend to be local with the potential for adrenal suppression. We use the technique described earlier, 30-gauge needle, 1 cc syringe, and use, again, 10 milligrams per cc. We inject up to 40 sites. Patients seem not to it doesn't seem to matter to them. And perhaps that's because in this disease, like the others we talked about today, there are some changes in nerves in this disease as well. And it may be that the tolerance for injections might be better for patients with alopecia areata than if these were done on you or me. So as I said before, the disease extent does not stop us from using intralesional injections. If a patient does not want systemic therapy, they want something better than what they've been doing with a topical, we offer them the idea and the possibility of injecting the area to see if they're steroid responsive. And then we tell them that 4 cc's will be about 40 spots on the scalp, and we tend to place them apart about a centimeter or more. And in this peculiar disease, if we put these many injections in, probably a third will respond and the other 2/3 won't. So then we just continue with injections until we sort of fill in the scalp. And some patients actually prefer this approach. So there came a time then when we wondered whether we were doing anything to the adrenal glands, and so we checked adrenal function doing an ACTH stimulation test prior to injections every 6 weeks for a period of 6 months, followed by a 6-week injection-free safety follow-up visit. And we found that the injections did not significantly affect the pituitary adrenal axis. So with that limited study, we have some safety data. Of course, if you look in the literature, you will see that if patients receive intralesional steroids for many, many years, that there is some evidence for changes in bone. So if we have patients on long-term intralesional corticosteroids, we will work with endocrinology if needed, or at least get assessments of bone density and talk about supplementation if required. Topical immunotherapy is a wonderful treatment. In Asia, it is the treatment of choice for alopecia areata, particularly in Korea. But in Korea today, just like in the US today, it's getting more difficult to get access to the compounds from the chemical storehouse. There is a lot of regulation that's coming into play in our being able to get these chemicals easily. So even though the DPCP is not specifically banned due to other aspects of increasing regulatory oversight, it's becoming more complicated. There is, fortunately, a company called RXI who has a DPCP gel formulation that they are studying for the treatment of warts and are now advancing very, very early pilot studies to see if this will work in alopecia areata. And if they go forward, it will be the first time that there will be a product out there that will have survived, will have undergone all the scrutiny that is required of medications. So then there's this kind of patient who walks into clinic, the adult who's totally bald, or could be the child. I don't know what you do with these types of patients, but I mentioned to you what we do is, if they're very conservative, we'll do an injection to see if they will respond. But the majority of the time, we do a biopsy to figure out what should we use. So we have all these treatments out there. What would be the best for that patient? And so the answer to this question about a scalp biopsy is yes, we will do one. And this is what we may see in a patient with long-standing alopecia areata. We have the follicular units present. We have a lot of sebaceous glands, and if you look closely, you'll find some follicles, and you'll find telogen follicles. So we may get a report back that says 50% of follicles in telogen, moderate lymphocytic infiltrate. And of all of our tools, we go, great, now what do we do? So we address the inflammation, and we try to use steroids again, and because of the hair cycle abnormality that's present, we do recommend Rogaine. The good news is with those JAK inhibitors is that the data from the studies that's coming out, when they look at the genes related to the hair follicle, and they look at the genes related to inflammation, it does look like with the JAK inhibitors, or probably most treatments with alopecia areata, that even if you have these very small miniaturized follicles and long-standing disease, if you have the right drug or medication or approach, one should be able to turn this disease around. So this is a case I'd like to end the presentation with. So this is a patient with extensive ophiasis alopecia areata. She's Ethiopian, her tests are negative. We go through our approach, which I discussed with you, but at the beginning we would be checking laboratory studies, and she was found to have a ferritin of less than 1 and a hemoglobin of 7.7. So we don't pursue treatment aggressively until these other associated medical problems are taken care of. She was also vitamin D deficient with a level less than 10, and that was addressed. And her biopsy demonstrated a 50% shift to telogen, no inflammation, and increased miniaturized hair follicles. So here we could argue the shift comes from being iron deficient, being anemic. Who knows if vitamin D is related to that or not? But we would first focus in her case on her medical issues. So in conclusion, until clinical research studies are completed, there will be ongoing debate regarding the risks and benefits, cost, and sustainability of the new approach with JAK kinase inhibitors or other different approaches as with interleukin-2. This is particularly true in pediatric alopecia areata. Our patients, physicians, we all look forward to the outcome of those trials with both topical and oral inhibitors, and to the results of the current studies, including the off-label studies. Our patients have resources. Please direct them to the National Alopecia Areata Foundation website. I do believe there is a translation in Spanish. Cosmetic camouflage can be helpful. The prosthetic devices available in 2016 are incredible. And you can refer to an organization for hair prosthesis for children younger than 18. alopecia areata has made some major strides over the past few years, and in November there will be a research summit in the